Hello, everyone. Thanks for joining us today on Facebook Live. I'm so delighted to this morning have Dr. Leigh Lewis with us. Dr. Lewis is a naturopathic physician, and she's going to talk to us today about the top 5 supplements, lab tests, and safe ways to balance hormones during and after breastfeeding and when to consider medications. Thank you for joining us today, Dr. Lewis. And Dr. Lewis is the only naturopathic physician in the state of Arizona to be certified as a women's health specialist. She's a graduate of Bastyr University and completed a 2-year postgraduate training program in integrative women's health. She is credentialed by NAMS as a certified menopause practitioner, ABORM as a fellow of oriental reproductive medicine, and PSI in perinatal mood and anxiety disorders as a prescriber. The only physician to have this combination of training and education. So we're so excited to have you here with us today so we can ask questions and hear about all these things that we need to be thinking about. You know, something that that comes to mind when I read your bio here is we had Elizabeth Wood come speak to us, I think in January, and she was talking about how some of the things that you don't take care of in the postpartum period can come back to bite you in menopause. So yeah, while I'm looking at your bio here, I'm like, oh yeah, you know, those things, you know, they span the lifespan. And I think that that's something we don't give enough attention to. So I'm just so delighted to have you here with us today. Welcome.
Well, thank you so much. I'm so excited to be helping out and here today at the 4th trimester group because I love what you guys do. And I think just really having a gathering space for women to get this information and this type of support is so important. And as we were just talking about, I mean, one of the good things that good, bad that happened with COVID is that I do think that this type of information is so much more accessible to people all over the state and even in rural areas. So hopefully, not that I know one of our guests is from Tucson, not that that's rural, but it's just so nice to be able to really be able to branch out and meet so many more people than I would necessarily in my location in Arcadia. So just kind of jumping in, I think it's so important for women to know that the duration of postpartum is really variable. So, you know, and you might read, and again, so many people have their own opinions on Instagram and Facebook, and doctors and therapists and spouses. Everyone has an opinion on how long this should last. But what the research really tells us that just came out, and this is literally just came out in 2020, that the duration of postpartum can actually last up to 3 years, where I think most patients and women are getting the information that 6 months, well, maybe 6 months, 6 weeks, 6 months, or up to a year. And Dr. Oscar Celorak, who authored the very excellent book, Postnatal Depletion, the postnatal depletion cure, which I'll have a link to on my notes, and I hope you guys can put a link to that great book. He suggests that postpartum issues can last as long as 7 years. And there's so many different things that can create variability for that time frame for each individual woman. One would be her experience just going through pregnancy. 2 would be the labor and delivery experience. We were just talking about the fact of different issues that if you don't take care of in your postpartum can creep back up later in life. And certainly pelvic floor issues would be one of those. And that's why one of my referrals frequently is to pelvic floor physical therapist, because I really want my patients to get support in the postpartum and not coming in as a perimenopausal woman with actually organ prolapse at that time. So the other thing is to the choice to breastfeed or not can really change the duration or the complexity for women with their postpartum symptoms. Anytime there is a period of hormone flux, it can really ramp up symptoms. And that's any of the mood, anxiety, depressive type symptoms, insomnia, and even physical symptoms like fatigue, headaches. All of these things can manifest in that time right after birth, huge area of hormone flux, but then also at the time of weaning and at the time of the menstrual cycle reestablishing, which again, depending on how long you choose to breastfeed, can really push that time out. So women who maybe were feeling quite stable in their postpartum, when they go to wean, and then again, when their breastfeed or when their cycle is reestablishing, they can see a flare up of those symptoms.
Mm.
The other thing that I would just like to discuss is that, this time of postpartum, for some women, it's, maybe it's after the first baby and they have this duration of postpartum that will last until they get pregnant again. Maybe they're not going to get pregnant again, but if there are multiple pregnancies and the patient is coming from a situation where she is depleted after that first pregnancy and postpartum, and then has another pregnancy and postpartum, and then the subsequent ones that are on top of that, sometimes that depletion can really just increase. And when I'm seeing women who've had 3 kids over 10 years and have had those periods of being pregnant, breastfeeding, pregnant, breastfeeding, pregnant, and breastfeeding, that patient is oftentimes just so depleted in nutrients, can have cortisol dysregulation. And the other thing to think about is that where are you after that 10 years? If you started pregnancy at 22 and you've kind of closed up shop at 32, that's very different than the woman who started her childbearing at 35 and over, say, subsequent pregnancies is finishing childbearing and maybe in the postpartum period in her 40s. And that is really getting into that situation where the postpartum is kind of bumping up against perimenopausal changes, and it can be very difficult to tease out what is truly going on at that time. So that's just important to know that, it just really depends on your age and just what your postpartum experiences have looked like. In terms of risk factors for postpartum issues, and here we're specifically talking about mood issues with anxiety, depression, OCD type features, or even into bipolar or manic type episodes. If the patient has had issues with PMS in the past or any of those diagnoses in her younger years, it is much more likely that she will have perinatal mood and anxiety issues come back during that time. So either during the pregnancy or in the postpartum. And again, there are all those flashpoints when she's going to be at higher risk for those symptoms coming back. Right after birth, with the cessation of breastfeeding, and then also with the menstrual cycle returning. The other thing is just to kind of get back, into perimenopause for a second. Perimenopausal changes also can really impact mood or physical and mental emotional symptoms. So again, that could be one of those issues that is difficult to tease out for those same reasons, because perimenopause is also a time of hormone flux, and so can really increase those symptoms at that time. So, just going into what is important, why is all this important, is it's just really important to know what your normal is. You are going to be the expert in what is normal for you. If you are struggling with weight issues, sleep problems, any of the mental, emotional symptoms that we talked about, PMS can happen and you can start to cycle without actually bleeding. So maybe you're noticing that every, 3 to 4 weeks, you start to experience irritability, low mood, increase in anxiety or sleep problems. That could be your cycle trying to reestablish, even though you didn't start to menstruate yet. So being, kind of on the lookout for that. The other thing is to really understand that a proactive approach is always best. I think a lot of us know that, and we see in media and on the news, the worst case scenarios, women who they can't get out of bed because they're so depressed, or they actually will have harm against themselves or their children, or are psychotic. Those are the worst case scenarios, and certainly the much more infrequent than women who have intrusive thoughts or just like free floating anxiety, worry that doesn't really seem to have a focus, but they're just like constantly on edge or worried, and or just a low mood or lack of interest in things that they would usually be interested in. And also energy, weight. I mean, I see women all the time who you might see her in the, the grocery store and say, oh, she looks like very healthy. But to her, she doesn't feel healthy, and she doesn't feel healthy in her body. And she feels that she has not been able to lose her pregnancy weight like maybe other people do. So it is really just kind of checking back in with what's your normal, what are you comfortable with? It's not for me to tell you that, oh, you don't meet this classification for the diagnostic criteria for depression before we start to do some things to get you some assistance. It is, you reaching out for help, with a therapist or with a prescriber or provider for you. The other thing to remember is that if we can interact and not be, and I do work with some patients who really do feel like their depression or anxiety is almost at the cusp of a crisis situation. And so they are really looking at that point for medication, and I'm happy to do that. But the other point is to remember that there could have been a time where we could have intervened maybe several weeks or months earlier, and we have the luxury of doing some lab work, trying some things like acupuncture, working on sleep cycles, some supplements or herbs. But that is really the key, is you really want to find a practitioner or provider that's going to really help you with the full breadth of your options. And what I always tell people is I'm happy to start, say, on this side of the continuum with doing diet, lifestyle, therapy referrals, assistance in that way. But there are women who come in who really are at that point where it's just, they are in such like really on the edge of that crisis situation where they do need medication and that therapy referral. And that's oftentimes a time where I will actually give them the specific names of therapists that I know are taking patients and I know specialize in postpartum care, because that is so important to get that assistance right away. The other thing is just to know that this is all completely normal. And just because you start a medication or start therapy in the postpartum phase does not mean you're going to be on that forever. And it doesn't mean that you're going to have to do, twice weekly therapy for the rest of your life. Oftentimes it's really just having that person to check in with, and, maybe doing 6 to 8 sessions of therapy. And then oftentimes the therapists that I work with, and I know that we have a lot of good options in this community, they're really trying to do solution focused therapy. So they don't want to see you once a week for the rest of your life either. So that's, you will always have that person to connect with if issues come up, but it's just important to get help sooner rather than later. Most importantly, too, during this time of postpartum, like I said, some women in their postpartum, maybe they don't have plans to have more children. But if they do have plans to have more children, then what we're oftentimes working with in the postpartum phase is that return to fertility, so that the patient can try to conceive on her timeline. I just met with a young woman yesterday who did an IVF embryo transfer last summer. She just delivered her baby, and she actually is thinking she has met with her reproductive endocrinologist already, and they're planning to do another embryo transfer next spring. So what we really went over her supplements, what things she could, stop right now, what things she needs to start back up again as she approaches that embryo transfer, to get her in shape for that. But the other thing is you don't want to fall off of the very basic supplements that all women in postpartum should be on. And quite honestly, I oftentimes say this is like the 5 supplement. I know that Dr. Oz has really fallen off in a lot of ways, but he used to, a very long time ago, like 10 years ago, he used to just have his 5 like golden supplements. And I kind of feel the same way. And I think that this is a really good basic outline for most women, if not most people, to be on just in general. And then just to know too, that the postpartum time, again, looking at perimenopause, if patients are done having kids, then we're trying to get her balanced during the postpartum, take care of any postpartum symptoms. But what can we do proactively to establish health and wellness for the rest of her life, so that she can be healthy and active with her kids as they grow? And so we're oftentimes looking at what can we do to decrease any risk for chronic diseases. I don't know if the gals on here know that if you have a history of gestational diabetes, gestational blood sugar issues, gestational hypertension, that will increase your risk for having hypertension, blood pressure issues, or blood sugar issues down the road. And so it is very important not to just say, oh, I had these problems during pregnancy. I delivered my baby, and so I don't need to worry about that anymore because they took me off the medication, everything's fine. That is true. But what we need to do, because you're just going to be at higher risk for all of those, we're all at higher risk for those things as we age. And so what can we do to reestablish some really healthy habits, both diet and lifestyle wise, so that we can decrease our risk for those future problems? The other thing is too, and I don't really hear that this is really getting down, this information is getting shared with patients from the OB perspective. But when you've had gestational diabetes or gestational hypertension, or if you've gained a lot of weight in your pregnancy, or maybe your pre-pregnancy weight was high, there is intrauterine programming that can set that baby up for future problems down with that. There was just a really good study that I was actually just listening to a podcast, and I was so happy to hear that this was kind of getting out into, because it wasn't necessarily even a medical podcast, but they were talking about that if mom is overweight or obese in her pregnancy, and that baby gets that kind of intrauterine programming for, set points for weight, and the baby is overweight, and then the child is overweight, and then that baby, that adult is going to be overweight. So one of the things is this can be a great time to really establish healthy dietary habits for the whole family. And so I do have nutritionists that I recommend and refer to all the time, especially if it's a couple that, has, just been the two of them for a long time, especially in COVID times, we've all established some like crazy eating habits. It's great. Again, this isn't something you have to meet with this person for the rest of your life, but you can meet with them 2 or 3 times, and they can come in and help you set up a healthy pantry, go through with some meal planning, and just help that, because it's not just a couple anymore, it's a couple and a baby, and that's going to be a growing family. That if you can, learn how to introduce food, and this is not anything I do, that's why I defer to the nutritionist. If you can lead that family in a path where they are introducing healthful foods to their baby and set up that healthy taste and healthy eating habits from a very young age, that child is going to go on to be much healthier as an adult down the road as well. So to the 5 supplements that are so important. Prenatal vitamin. I have all women stay on their prenatal, whether they plan on trying to conceive again or not. Once they hit 50, they can come off of their prenatal. Also for younger women, even if they're on a birth control pill, I have all of my patients, and again, I start seeing women and girls as young as 14 or 16 years old. If one of the prescriptions that I'm giving to those kids is a birth control pill, I want them to be on a prenatal as well, because it increases their need for B vitamins and folic acid is a B vitamin, but I want them to have that like basic nutritional plan just as they go into their life, and then like in trying to conceive down the road if they choose to do that. But for women, as they're in between pregnancies or in postpartum, it's so important to stay on that prenatal. And there's no need for a specific postnatal. I do see that marketed. A prenatal is just fine. You're going to get everything you need from that. It doesn't need to be anything fancy. Vitamin D, and I say based on labs, conservatively 5,000 IUs per day is likely safe, especially if you're breastfeeding. You're going to have extra need for that vitamin D. I don't recommend more than that, but I do recommend that, 6 weeks to 3 months postpartum, and we'll get into this in a bit, that vitamin D is one of the things that you get checked to make sure that you're taking enough. Because oftentimes I have patients, I just met with someone the other day and her vitamin D was down at 25. It's still somewhat within, it's not the optimal, but it's within the normal range, but she should really be up around 50. She needs enough vitamin D for herself and then also in her breastfeeding. We also know that vitamin D is very important for decreased time to conception. And so you want to have that on board if you plan on getting pregnant again. It's also very helpful for energy and mood stability as well. Fish oils, 1 to 2 grams per day. I'm a big fan of the Nordic Naturals brand. I think they're very healthy. You can get them on Amazon. I love the Pro Omega 2000 because it's just 2 pills and you're getting 2,000 milligrams or 2 grams of the EPA and the DHA. So because, you might think you're saving, and they're not cheap, but you might think you're saving money if you get another brand, but you could oftentimes be taking up to 8 pills to get that much. And I don't know about you, but that is not good for my stomach to take that many. And actually Nordic Naturals, I find very well tolerated for patients. It doesn't tend to repeat on you, and it's worth the money for sure. A probiotic, especially one that has Lactobacillus rhamnosus. Both the probiotics, the fish oil, and the vitamin D have all been found in research. And again, that Lactobacillus rhamnosus strain to be helpful for postpartum depression and anxiety. Lactobacillus rhamnosus is in a lot of formulas. I really like the probiotic pearls. They actually have a women's complete. It is a very good formula for vaginal and GI health. It does not need to be refrigerated. It is super small. I mean, it literally is like a little pearl. So for those people who don't really like to take pills, it's just very easy to take. And again, that's something that I have all my, like 99% of my patients, I feel like as long as we come up with more and more information about how important the microbiome is for so many things in our health, that there's very few people that I don't recommend that to. And then finally, the L-methylfolate or folate that you may be familiar with in terms of this genetic test. And I don't want to get too much into this, but there is a genetic test called the MTHFR gene, and that will tell you whether you do or don't have a decreased ability to metabolize folic acid. And so it is very important to have the folate type of folate, that B vitamin, in your prenatal and or take it separately. This L-methylfolate actually is a supplement that many psychiatrists actually use with or without the test. That's what I wanted to go back to. You don't necessarily have to do that genetic test to find, because it's safe to use whether you have it or not. And then if you're on this form, it's protective if you do have that genetic mutation. The reason I'm not testing everyone is insurance does not love to pay for genetic tests. So I don't want you to get stuck with a $300 lab fee for something that we didn't really need to test anyway. In medicine, often if we're doing a lab test, and we'll get to this in a second, it should really change our treatment, give us some more information to help us make a decision on different treatments. And this doesn't really impact that. We're going to want to use the L-methylfolate version either way. There's one that is on Amazon. It's called Methyl Pro. It's a 7.5 milligram. That's excellent for mood and anxiety disorders, PMS issues, or just general depression and anxiety in general. Even if I'm prescribing a medication like sertraline or fluoxetine, I always have some patients use this too, because what the studies have found is if you use L-methylfolate, you can oftentimes get better control of the symptoms with the medication at a lower dose. And so we'll talk about that in a second, about the safety of the medications. But we also know that L-methylfolate is very important in terms of fertility, and all the reproductive endocrinologists that I work with do a separate L-methylfolate on the side of the prenatal vitamin. And so again, that's all very important. So those are the top 5. Prenatal vitamin, vitamin D, fish oil, probiotic, and L-methylfolate. And again, this is something that even my 70-year-old patients are on most of those. Not a prenatal, because once you've closed up shop, there's usually an over 40 multi or an over 50 multi that we can switch to. But for anyone under 40 or 50, they're on a prenatal, and this is a great combination for just general health.
Hey, Leigh,
Yeah.
I hate to interrupt, but like we're all over here like, this is so amazing, and I love all of this information. I want to make sure you're on a roll, but we've got some questions in the chat, and I'm not sure if we're going to stray from the topics a little bit. Yeah. Can we go through and maybe address a couple of them before you move on? Yeah. So we'll have a few questions. Let me scroll up here. Let's see. First of all, love that book by Dr. Oscar Silarek.
Yes, Oscar Silarek. That's great.
Amazing. We put the link in the chat for everybody. And I put the Amazon link online, although I didn't preface it. So it's just a random link, but that's the book. So if you're on Facebook and looking at that link going, do I want to click this? It's just the book on Amazon. A couple of us have heard about putting our fish oils in the freezer. Yes. Is that okay to do? We've heard about like the whole like fishy burps.
Yes, and I have heard that too. That like I said, I think the Nordic Naturals is the least likely to do that, but that is another pro tip. Very good.
Okay, cool. So it checks out. All right, good. Tiffany says she's one of those lucky MTHFRs.
Yes, I know, and that is a big joke in medicine too.
Demi and I always giggle about that. Megan also graciously popped in your notes from your conference session into the chat. So if you are joining us in chat, everybody, you can access those notes. And then somebody's wondering about a Dutch test, say for someone who has done the full blood lab panel for hormones and isn't providing answers.
Yeah, so, well, okay, let me back up just a second, just to say that there are, yes, you can go crazy with all these different tests that are out there. I find that most of the time checking blood labs through, I use SonoraQuest or LabCorp, covered by insurance. If you do have that coverage and you've met your deductible, blah, 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 all the caveats I need to say, that gives us I'm honestly 99% of what we need to know. Unfortunately, with the Dutch test, I have found, and kind of did this small study, if you will, of they give each practitioner, if you're interested in using it, you can get like 5 tests for a reduced fee. And if I have patients that were interested in doing it, I gave them that test. And with the caveat that I can't say that it's really going to change our treatment, but I then compared the results to what we got on blood, and they were wildly different. And so I don't find that it really is all that helpful. The other thing is too, is that if something comes up abnormal in the Dutch test, say for example, something comes up abnormal and I want to then refer that patient to an endocrinologist, conventional medicine is not going to want that, or it doesn't help at all. So I need to then repeat it with a blood test anyway. And that's what I would do anyway for my own information if something came back. So I personally don't necessarily find the Dutch testing that helpful. And I feel like too, a lot, and again, this is getting a little bit off track, but just basically, it can be a moneymaker for the provider who is doing it. And then also it can cost up to I've heard like some providers charging $500-$600, and I just don't feel like it gives you any extra information. So that's what I would say on that. You can test estradiol if you wanted all of those like extra hormones, estradiol, estriol, estrone, the 3 types of estrogen, testosterone, DHT, everything you can check on a Dutch test, you can check on blood. And as long as we have the right codes, you should be cortisol, same thing. If we have the right codes, you should be able to just get that covered by your insurance. So I think it's a little bit of a marketing thing. And I do think that to me, I don't want patients to have to spend a ton of money if they don't need to. So, which usually they don't.
I hear you there. Yeah, I definitely understand that feeling.
One other caveat is there's a lot out there too on like this Paloma is another direct to consumer test, which does like a lot of female hormone testing and I think thyroid. Again, this is not giving us any more information than what we can do with a blood test. And honestly, you should be able to ask your doctor, like say for a thyroid, if you want to check, TSH tells us what our brain is telling our thyroid. If you want to know what those T3 and T4, your actual thyroid hormones is, ask your doctor. If your doctor is like unwilling to do it, then you need to find a new doctor, because even now, I see an internal medicine doctor because I've had a lot of health problems, and she totally is open to ordering those things for me. There are those doctors out there, but I just think that I have also had wildly different levels between the direct to consumer tests and the blood tests that I trust. And also, if you're just interested in like the whole Theranos scandal, I very highly recommend that documentary on HBO. It's creepy. How much people spent on those tests, and it was all fake. It's all fake. I can't say that about these other tests, but I don't know. I'm a skeptic, I guess. So anyway, that's my rant.
Yikes. Yeah, no, better to be aware before going into all of this. And I think this is really valuable information for everybody. I have 2 more questions in the chat here. One regarding if you have a favorite brand of prenatal, and then also about the supplements that you just listed, those 5 key supplements. Any recommendations on taking them? Should we take them together? Is that okay? Should we space them out? Is there an optimal time of day?
Yes. So actually, any of these pills can be taken morning, noon, or night. I do like to space them out, or just have with your heaviest meal. It's usually the absorption's pretty good. We didn't talk about iron there, and that's really only because you should only take iron if you need it. But iron is really the most persnickety supplement. The other things you can take all together, you can spread out, you can take them anytime. In terms of a favorite prenatal, I really like the one that you tolerate best. And so I oftentimes tell patients, especially if they're trying to get pregnant and they're like, oh my gosh, I'm on this one that's 8 a day and it's making me nauseous. That is not going to be a good recipe for when you actually are pregnant and are nauseous. So it's just, You know, there are many out there. I do like Smarty Pants, and that can be a really great one for women, especially if they do have a tendency to get nauseous or have problems swallowing when they're nauseous in pregnancy. Elizabeth Wood has an excellent spreadsheet on her website, and that's where I typically send patients to. But I also like, I just really ask that patients get the one that has the L-methylfolate form of folate in it. Thorn is another great one. And to just try to really look at ones that are like 1 or 2 per day, or again, chewables, so that they can tolerate that throughout pregnancy into postpartum. You know, you don't necessarily want to be worrying about a 3-time-a-day dosing when you don't even get a chance to shove something in your mouth at noon. You know, is not, you don't want to be thinking about what pills do I need to take. So, you know, usually that 1 a day, if you can find it, or a 2 a day, you can take it all at the same time. Those are the best ones, I think.
Awesome. Thank you so much. Yes, I think that is to the end of our questions currently in the chat. So take it away.
Okay. So I did just want to go on to labs. We talked a little bit about this. I really like to check this 6 weeks, 6 to 12 weeks post-delivery. Sometimes if women have already had a thyroid problem beforehand, I have had some women, and I'm not sure, you know, it just can be difficult to get in with your OB to get some of these things done. And I'm always happy to just put the order in, and then we can follow up, you know, again on the phone or with a, you know, my telemedicine, just so she doesn't have to come into an appointment. There's also Unique Labs, which is one of the lab services that I really like. It will come out to your house, so that's very convenient for postpartum. But you know, so sometimes with the thyroid, pregnancy can increase your need for thyroid. And I just saw a patient right at 12 weeks who was not feeling well, and sure enough, her thyroid dose was way too high for postpartum. She needed that in pregnancy, but we had to really scale her dose down because she was actually hyperthyroid on the current dose in postpartum. So that's not healthy either. We got that taken care of. So again, reach out if you're not feeling well, but usually around 6 to 12 weeks is when I like to, and again, a top 5, I'm going to kind of try to make it easy here, is I really like to check a TSH for thyroid. Our goal for thyroid, just generally, again, this is your brain telling your thyroid what to do. So most women are going to have a low functioning thyroid, and that is your brain is yelling at your thyroid. So the TSH level goes up, and that's sometimes really confusing because you're like, what? Well, that's elevated. And you said, you know, my thyroid's underactive. It's because your thyroid is not behaving that the TSH level has to rise to yell at it. So we really want, in a normal range that goes from, like, say, depending on the lab, 0.4 to 4.5. You can walk around with no symptoms and be at 4.4 or 4.5 or 4.6. But if you have symptoms of hypothyroidism, which are all over the internet, and basically mimic postpartum, hair loss, a weight loss issue, like you can't lose weight, constipation, fatigue, difficulty sleeping, low mood, anxiety, yeah, blah, blah, all the stuff. We really want to possibly try you on a thyroid replacement to get that TSH level below 2 to 2.5. That's really ideal, especially if you plan to try to conceive. We want to set you up for success. And that's really where any reproductive endocrinologist or anyone who's treating anyone who's trying to get pregnant, we really want that TSH level as in that ideal range so that you feel as good as you can. And if you do want to try to conceive, you have an easier time with it. Vitamin D, our goal is around 50. And that's why, again, I don't want people just picking up a 10,000 IU on Amazon, because it's not hard to overshoot that mark. If you make your vitamin D too high, it'll actually cause this weird thing in your body where your body will start to leach calcium from your bones. not good. So we do want to, you don't want to just take vitamin D willy-nilly, and more is not more in this situation. So you could start at 5,000, but really you should be checking in with someone at least at 3 months and make sure that that isn't too high for you. B12 is very important in the postpartum. B12, D, and iron, as we'll talk about in a second, all get leached from mom's body. That sounds terrible, leached, leached by the leech, but in pregnancy and postpartum. So if you've had a baby, so you could already be low on these. So it's good to get them checked in postpartum to make sure that your postpartum symptoms that everyone says is totally normal could be exacerbated by low or low normal levels of these 3 top vitamins. And sometimes the prenatal is not enough to keep you in the normal range. So again, vitamin D, our goal is around 50. B12, our goal is around 800. You have to be actually under 200 to be vitamin D deficient, depending on the lab, or B12 deficient, but still you will feel so much better if you truly have suffuse amount. Again, no point in going into the super physiologic range or outside of that high end, but we do want you higher up to that high end. Ferritin, which is our iron stores, goal is around 50 for that. Ferritin is a protein that's produced by the liver, and it actually carries your iron around the blood. So it's a really good marker for how much iron you have to give to your baby and to do everything you need to do. If you have any biochemistry or chemistry from even high school or college, and remember the Krebs cycle, which no one wants to go back to drawing out, you'll remember that iron and B12 are cofactors in so many of our reactions that produce ATP, and ATP is energy. So we really want to be having those levels at a nice and suffuse. There are so many studies that show even if your ferritin is in the normal range, if you're below 50, and I recently just saw an article that said really our goal is to have you closer to 100, it could be leading to fatigue, brain fog, hair loss, a lot of the things, again, that we just attribute to, and any mood, all of these, the mood, anxiety, depression, can really be exacerbating those issues as well. And then cortisol, I just like to check in morning cortisol. You have to go before 9, and our goal is right in the middle. Cortisol gives us a burst of energy in the morning so we can get up and get going what we need to do. But what oftentimes happens is it's not too likely that we see what everyone talks about is adrenal fatigue, but it's more in postpartum. I find that their levels are too high, and it actually will be just outside the high end of normal. And that can really feed anxiety. It's caused by stress. You can get stress in your body, perceives stress, even good stress, as stress. So people who are over exercising, not necessarily in postpartum, but these are other people that I check. But exercise we think of as an excellent thing. But if you're doing too much of it for you, that could be overstressing your body. Having a new baby, this is great. But if it's causing you a lot of stress, you're not sleeping, just trying to balance everything, that transition with a new baby, it's not uncommon for me to find that elevated cortisol. It will feed that anxiety, and it will also interfere with sleep at night. So we want to bring those levels down, and there are ways to definitely do that. Hormones, I already talked about the direct-to-consumer labs that I don't love, but hormones, it doesn't give us a lot of information. Like I said, postpartum, and quite honestly, most of women's lives, you have to check these hormones at very specific times. Estrogen and follicle stimulating hormone need to be checked on cycle day 3. Progesterone needs to be checked on cycle day 21. I get labs all the time from all these different providers, and they're checked just like, just sometime, maybe the woman hasn't even started cycling again. It tells us nothing. So I don't love to, that's why I don't check them. I also don't like to check them a lot in perimenopause for the same reason. We can check from week to week to week and get wildly different numbers. And so it's just why people, it does not mean, also I should back up a second, even if they're in the normal range, it doesn't mean that hormones are not contributing to your symptoms, whether that be weight issues, whether that be menstrual cycle problems, whether it be mood problems. So that's another thing. Again, we're getting back to that situation. If we did this test, how is it going to change our treatment? And this doesn't inform our treatment, unfortunately. We still might try a progesterone only pill in, if you're breastfeeding, postpartum. We might try progesterone cream. Those things are safe with breastfeeding. Or again, the progesterone IUD. I think a lot of women choose that too. Very safe with breastfeeding. If you're not breastfeeding and having issues with postpartum depression, anxiety, irritability, maybe we'll do an estrogen progesterone combo pill. Maybe we'll maybe we'll still choose a progesterone, even though, because we can do that at a very low dose. And again, it's also important to keep in mind, like, what are the fertility plans? If there's no fertility plan anymore and you're in maybe that perimenopausal phase, maybe we choose something that's a little more longer acting. But if you want to get, like say that patient I saw the other day who's going to try to conceive again in a year, there's no sense in going on a birth control pill, because then we're going to have to get you off the pill and then reestablish normal ovulation, normal cycles before you can try to conceive again. And that can take variable amounts of time depending on the woman. Additional labs, I have this on my list. I would jump to maybe testosterone and DHEA. Sometimes they do like to check, especially if you are above 30. Definitely if you are above 40, because those can really interfere with our ability to kind of feel like ourselves. That's oftentimes what I have women come in and say. They're just like, I'm not able to maintain muscle mass. I just don't really have, it's just like, I just can't be bothered to have sex. I can't be bothered to go hang out with my friends. I just don't really have that zhuzh. And so sometimes low testosterone, and again, this isn't even low normal. For SonoRequest, anything under 12 is considered undetectable. It is not uncommon for me to see 40-year-olds who have their testosterone below normal. If you're trying to get pregnant, want to get pregnant, or breastfeeding, this is not anything we need to do, because we're not going to give you testosterone. But if you are done and you're just trying to kind of get yourself back, we definitely can test that and treat that. So, and then I would just point out too, just also, when, again, for those patients who are done having babies, just trying, that postpartum period is going to phase into just general life. Maybe you've never had your lipids checked, your cholesterol, doing just a comprehensive metabolic panel, look in the liver, kidney function. How is your body handling blood sugars? We need to, again, get you set up for success with the rest of your life, not having chronic diseases, so you can be there for your kids and your grandkids and great-grandkids. I had a patient, this is so cute. Yesterday, she's from Africa, and she just got back from visiting her mom, who she hadn't seen all during COVID in Africa, in Senegal. And she was 110 years old. Not my patient, the mom. So it was pretty amazing. And so it's just it's so cute. So, I think we have to consider that. I did a lecture on menopause to a group of nursing students, and I just looked this up because I wanted to talk about how we're kind of outliving our ovaries right now, like this kind of theme behind that. And in 1920, 100 years ago, the average age of life expectancy for a woman was 54. Now it's 82. And I'm sure, it's not uncommon. I mean, actually, my mother-in-law is 95 years old, and it's just not uncommon. So we have to really be thinking of that next phase of our life. We are outliving our ovaries for sure, which is a menopause talk. But the other side of that is, what are we going to do to keep ourselves healthy for the next half of our life? That's what I got.
Yeah, super interesting. Wow, I'm taking notes this whole time. I'm writing down all these things. Yeah, I think you gave us all a lot to think about, but one of the things that for me, right, I'm 43, and so my youngest child is 6. So for me, for sure, the postpartum phase really kind of butted up against perimenopause. And so now that I'm, kind of in that weird swing of my cycles and everything else going on, I stopped breastfeeding 2 years ago. So I had to go, okay, well, this is just what was happening anyway, or did I stop breastfeeding and that caused it? Yeah, it's really interesting. Mm-hmm. Yeah, and then how postpartum mood and anxiety disorders might slide into there, and then you don't know where those ended, and perimenopausal symptoms began. So yeah, I think all that's really fascinating to think about. It's not something I had really considered before, but you're right. Yeah, it just slides right past you.
Well, and the average age is 50 for menopause. Research shows that you can start having perimenopausal symptoms, which isn't all about night sweats night sweats and hot flashes, which is what everyone talks about. But you can start getting those symptoms 10 to 15 years before your last menstrual period. So that's like 35, So that can be, we know one of the earliest perimenopausal symptoms, which all of us know, is our fertility is going to drops off after 30, another big dip after 35, and then a huge drop off after 40. So it stands to reason that we're going to have some, depending on the person, some of those other symptoms come up. And I think so many times for moms too, they're just told, you're like, I had a patient, it was so funny. She was getting sick all the time with her, preschoolers and everything. And she said to her pediatrician, she's like, oh my God, when is this going to end? And she's like, he of course, he said, well, when are they going to college? So I think moms are just pretty much told, you're going to feel like crap until, your kids are out of the house, basically. And I think they just, so many times just let a lot of, it's, again, I don't want to blame the victim, but you just kind of let a lot of things slide because you just expect to feel bad when that doesn't necessarily have to be the case. And it may be that you have a child that's a problem sleeper, or maybe you have a special needs child and you just do have a lot more stress that will continue past those typical times when most women feel better. But it also could be some of these things that we discussed that are exacerbating those problems. And if we can address those issues, we can turn the volume down on some of the symptoms that you'll feel.
Yeah. Wow. Yeah. Super interesting. One of the interesting ones for me was the thyroid. As a lactation consultant, that's like the number one thing we check when moms are having lactation problems. And I'm hypothyroid myself. And I experienced what you talked about, where they actually increased my thyroid medication during pregnancy. And with my second baby, I was having trouble letting down, and I was agitated all the time and hot. And I thought it was, I'm just postpartum. Like, it's fine. Like and I remember my doctor was like, how did you not notice? How did you not notice that you were so high? I was like, I don't know. I was postpartum. I felt awful anyway, right? And I thought it was my baby just being super impatient at the breast. And when they checked me, they were like, your TSH is 0. So yeah, right. So, and I see that super often with moms who are either they already are on thyroid medication or they haven't been, but no one has checked them, right? So that's really, I'm so glad that you pointed that out, because I feel like that's a big missing piece for a lot of our mamas that are dealing with breastfeeding problems too.
Well, like I said too, some women will stay totally consistent and not need an increase. And that I'm less likely to be bugging her about, like, let's check your thyroid, let's check your thyroid. Yeah. But if you did have an increase during pregnancy, it's oftentimes you'll need to come back down to your pre-pregnancy dose. And again, if she just can't get in, or for one reason or another, sometimes too, I deal with patients who obviously don't have insurance. And so maybe it's not like thinking, oh my gosh, we really need, I really need you to spend this money. It's like, let's just get you back on your last dose of it, just to be on the safe side.
Yeah, that makes total sense.
Check back in later. So
yeah. Does anybody else have questions? I know we had a few just like, yes, as you were talking. Oh, and yeah, Sarah had asked about what if we don't know our cycle? So I think that's an interesting question too. Yeah.
Yeah. Oh, that's great. And that was, I posed that right before you had said, like, well, hormones are going to be really tricky, basically, to, get an accurate portrayal of what is actually happening. So, but yeah, like if we're not tracking, or, like a postpartum mama, if we haven't had a period yet, since our last baby, how do you, and you did talk and relate back to kind of like symptoms without a cycle, I just feel like I'm a hot mess all the time.
Well, first things first, I really do love those trackers. I like Clue is oftentimes the one that I recommend. You know, and especially if you're trying to track if you're really wanting to be more detailed with your symptoms, like I have some women who have like menstrually related migraines, or you know, you really are trying to get, because the issue, say with PMS, this is another thing that's not talked about a lot. We don't have a cute name for it like PMS, but pre-ovulatory syndrome. I see women with that all the time, like right around ovulation and right before ovulation, they feel their anxiety spikes, they can't sleep, they're moody. And so you can, if you can imagine, you can have that happen and then you ovulate. Or what if your PMS lasts for 2 weeks? You could have 3 weeks of the month where you feel terrible. And so it does really help us to be able to track that. And some women think they have PMS, but when they actually track how their symptoms are, they actually are having mood dysfunction all month long. It just gets way worse. So we would have what we call premenstrual magnification during that time. But that's really important for me. Whether I'm doing like maybe a supplement or an herb to help them with that, or a medication, because there are some medications you can, like Prozac, it used to be called Serafem, marketed like that, where you just use it for 2 weeks of the month. But if you're actually having symptoms more for 3.5, why not take it every day, you know? So sometimes that type of information can be very helpful. So I really do suggest women use that tracker. You don't have to fill everything out in it. You know, as a perimenopausal woman myself, I just moved to the health track or health app on the iPhone. You can just put, I started my period day 1. So you can just look back and it'll tell you where you are, like how long your cycles are. That's all I really want to know. And that can be so helpful. And you can even just track how your moods are, again, like are you having these moods without having your period yet? If you come to the point where you have stopped breastfeeding and you're getting to that 3 to 6 month mark and you still haven't had a period, that's probably a time to check in. Is your thyroid okay? You know, maybe again, if you were in that perimenopausal phase, maybe we just need to start waiting to see if another period happens, because maybe you're not going to have another period. Anything after 40, if you stop having a period, that's normal. So like I said, even though most women are going to stop their period around 50 to 51, you can stop after 40 and that's completely normal. And so, but a lot of times if you're not tracking, if you had your kid at 40 or thereabouts, some patients I work with are 42, 44, you know, you might not even be thinking about having, you're probably happy you don't have one. So then you have to think back and it's like, well, when was my last period? And if you're thinking like, oh, it's been before I was pregnant and my kid's now 2, you may already be menopausal. So
yeah, that's super interesting.
did that answer your cycling question? Yeah. Okay, good.
I have a question about tracking a cycle when you don't have a period because of a surgical intervention. I had a hysterectomy when my child was a baby. Mm-hmm. And I have had the hardest time. I actually just clicked on your link and to schedule an appointment with you. But so we can talk more in depth because it's probably too complicated, but I have had the hardest time. My husband's been requesting that I like chart, you know, other symptoms. But it's so hard. Do you have like tips for somebody this is a very unique situation, I suppose.
Well, I mean, and it's not. I mean, there are women who, for whatever reason, have their ovaries removed. Now, that's obviously very different. That is a surgical menopause. You are considered surgical menopause because you're not going to have a period again, but you still.
And I have one ovary. I had just one.
Okay.
Yeah, I had to lose the other ovary after the hysterectomy, like years after, because of an emergency.
Newer way to look at this, but we do know that women who have their uterus removed, even if both ovaries are there, or if they have a tube removed, if you can imagine, if you haven't had occasion to actually see a hysterectomy being done, or just like any type of pelvic surgery, I mean, it is just all jammed in there. I mean, for lack of a better word, and it has no reflection on the surgeon at all. There's going to be blood and nerve flow damage done that will impact that one even if just the uterus is taken out, that will impact the functioning of the one remaining or two ovaries that are there. So we do know that women who've had a hysterectomy, even if both ovaries are remaining, they potentially will go into perimenopause or menopause sooner. Like true menopause, meaning that your hormone levels will drop. They used to tell, when I graduated 20 years ago, the surgeons used to tell their patients, oh, that ovary will pick up the pace for the other one. And that's just not played out. So it's not uncommon for you to have more. And then again, too, you'd still be having all of the postpartum issues, but it's not uncommon to have, you know, potentially more of those perimenopausal symptoms mixed in. So yeah, so that it might be a situation. So if you want, just email me and I'm happy to give you, because sometimes too, it's nice to do it on I have a very nice, I wouldn't call it just PMS, because again, you're not even having a cycle, but a nice hormone and hormone symptom related chart. So you can kind of chart how things are coming, and you'll see if it's every, you know, 3 to 4 weeks. And that is something that's likely, hormonally related without having a period. Mm-hmm.
Thank you.
Yeah.
So I want to pop us off Facebook Live just in case there's any questions that we don't want to share in here. I know Tiffany has a question, so I'm going to go ahead and pop us off. If you're watching us on Facebook Live and you want to ask Dr. Lewis any questions, please join us on the link, but I'm going to pop us off right now.